This video demonstrates the technique of tracheobronchial anastomosis for congenital absence of the right bronchus. The patient was an 8-month-old child who had a complete whiteout of the right lung, and there was no bronchial continuity seen on the right side on bronchoscopy. A diagnosis of congenital absence of the right main bronchial stem was made, and surgery was planned to attempt to restore the continuity of the right bronchus. Here we can see the bronchoscopic view, which shows a continuation in the left main bronchus. However, the right bronchus is seen to end blindly about 1.5 centimeters below the carina. It may be possible that the discontinuity of the right bronchus was due to some kind of inflammatory process or stricture formation after birth, as embryological absence of the right bronchus would conceivably lead to failure of development of the right lung. Once the discontinuity of the right bronchus was established, the lesion was approached through a right posterolateral thoracotomy, entering the chest through the third intercostal space. The skin was divided in the line of incision a little below the inferior angle of the scapula, and the subcutaneous tissue and muscles divided in the same line to access the ribs and intercostal spaces. The subcutaneous tissue is now divided in the line of incision. So that is the latissimus dorsi muscle being divided in the posterior part of the incision, and similarly the serratus anterior will be divided in the anterior part to access the ribs and the intercostal spaces. Here we can see the serratus muscle undergoing division. There is some talk of preserving the long thoracic nerve of Bell to prevent subsequent winging of the scapula. However, with our experience of esophageal atresia, we have not seen winging of scapula in many patients. The last part of the serratus muscle being divided, and the final few fibers of the latissimus dorsi, and underneath we can see the ribs and the intercostal muscles. The surgeon's index finger is introduced under the scapula to count the ribs from above downwards, and in this patient we have decided to enter the thorax through the third intercostal space, which can be seen just underlying the tip of the scapula. And that is where the muscle is now being divided at the upper border of the lower rib, as is customary. Due to the lung being non-aerated on the right side, the ribs are set pretty close together and the intercostal spaces are quite narrow. As the phenociator retractor is inserted and spread, we can see that the underlying lung is collapsed. There is a movement with respiration which is due to the diaphragmatic excursion. However, the lung is not getting aerated and is not expanding at all. Also, the color is grayish instead of the normal healthy pink. The lung was also seen to be fairly adherent to the chest wall and therefore is requiring finger dissection to separate it before we can access the hilum. By readjusting and opening the retractor a little wider, the exposure becomes a little better and it is possible to see the grey non-inflating lung on the right side. The lateral part has almost been freed up and we can see the lateral chest wall with the azygos vein beginning to come into view on the medial side. As there was no length of bronchus on the right side at all, it is important to mobilize the lung completely so that we reach the bifurcation of the trachea at the mediastinal level to perform the anastomosis of the stump of the right bronchus to the bifurcation of the bronchi in the lung. Here we are beginning the mediastinal dissection using a Rumel's artery forceps to expose the bifurcation of the trachea. The first step is to lift away the mediastinal pleura overlying the tracheal bifurcation and the inferior vena cava. And after opening this, we should be able to see the bifurcation of the trachea and the stump of the right main bronchus. So that is the mediastinal pleura being divided, carefully held up in the jaws of the Rumel's artery forceps. We continue to dissect the mediastinal pleura on the right side to try and identify the hilum of the lung and the tracheal bifurcation. The pulsations of the aorta can be clearly seen, and the vagus nerve is about to come into view. Clearly, a degree of patience is required for this step of the operation because there is no significant length of the right bronchus available to be identified, and it is purely by feel that the tracheal bifurcation can be dissected clear. So just under that gap in the mediastinal pleura, where the tip of the Rumel's artery forceps is currently, is the bifurcation of the trachea and the stump of the right main bronchus. So we can see that we have exposed the stump of the right main bronchus on the side of the lung, and secretions are coming out from the collapsed lung, mucoid secretion. And this is the point of bifurcation of the main bronchus into the upper and lower lobe main stem bronchi, which has been opened. And this will be the point which will be anastomosed to the stump of the right main bronchus. So we are testing distal bronchial patency using a feeding tube towards the upper and lower side. And after this will be the turn of exposure of the stump of the right main bronchus. We are now applying stay sutures in the exposed bronchial bifurcation of the right lung to keep it in vision till the stump of the right main bronchus on the tracheal side is exposed. The lumen of the bronchial bifurcation being tested on both sides, and one can see mucoid secretions flowing freely from the till now collapsed lung. We are here attempting to introduce a flexible bronchoscope into the bronchus of the right lung to see whether the remaining distal bifurcations are patent. Unfortunately, as the size of the bronchus was too small to accommodate the bronchoscope fully, we could not get a clear picture of the situation inside. There you can now clearly see the upper and the lower bifurcations at the hilum of the right lung, and this is where the anastomosis will be performed to the stump of the right main bronchus on the tracheal side. From the amount of fibrosis which is present around the bronchus at the hilum of the right lung, it seems as though the obliteration of the bronchus has been due to an inflammatory process rather than being congenital. At this point, we can clearly see the upper and lower openings of the right upper and lower main bronchus diverging from the tracheal bifurcation and held up in the stay sutures. We are now dissecting the mediastinum just underneath the hilum of the lung to locate the trachea and the stump of the right main bronchus, which will be anastomosed to the bronchial bifurcation at the lung hilum. The trachea lies just underneath the tissue which is being held up in the Rumel's artery forceps, and there is an extensive degree of fibrosis in this region, perhaps from an inflammatory origin. And therefore, we have to keep persistently dissecting away at this fibrotic tissue until the stump of the right main bronchus is brought into view and mobilized sufficiently for anastomosis to the lung hilum. Now we can see the trachea coming into view there, and the stump of the right main bronchus will underlie that lymph node. The tissue at the tip of the stump of the right main bronchus is held in the thumb forceps, and we will now apply a couple of stay sutures to secure the stump, open it, and then anastomose it to the bronchial bifurcation. just clearing away a little more of the fibrotic tissue which is holding up the stump to get a bit more length for an easier anastomosis. Held up in the single stay suture, you can see the tip of the stump of the right main bronchus coming into view. It is really short, just about a centimeter in length, and we are just making efforts to mobilize it as far as conveniently possible to be able to anastomose it to the lung. A feeding tube has here been used to protect the azygos vein, as the stump of the bronchus is lying underneath it. There is a lot of fibrosis enclosing the azygos vein as well. We are continuing the dissection of the fibrous tissue overlying the stump of the right main bronchus, purely in order to get a little more length to make a tension-free anastomosis with the bronchial bifurcation. As is obvious, there is a considerable amount of fibrosis in this area, and that is making the dissection a little difficult. So we are using a combination of blunt and sharp dissection as the need arises. Eventually, we have cleared up a sufficient length of the stump of the right main bronchus to be able to perform the anastomosis with the hilum of the lung, and we'll now apply a stay suture on the other side of the stump and open it between the stay sutures to effect the anastomosis. So there you can see the stump of the right main bronchus being held up between the two individual stay sutures, and this will now be opened for the anastomosis. We are just testing that the bronchial bifurcation can approach the stump of the right main bronchus comfortably without tension, and it seems to be doing that, and air is being aspirated into a saline filled syringe to confirm that this is indeed the stump of the right main bronchus, which will now be opened to join it to the lung hilum. As you can see that the stump of the right bronchus is not very long, and it is densely encased in fibrous tissue, which has to be carefully cleaned away, otherwise it is liable to constrict the anastomosis subsequently. We are opening the stump transversely as the pulmonary hilum goes from above downwards, and there you can see the Rumel's artery forceps entering the lumen and a little bubble of air coming from the stump. We are enlarging the opening in the bronchus a little bit to give a wider anastomosis. The width of the bronchus here is just about a little over a centimeter, and this is not as wide as the bronchial bifurcation in the hilum of the right lung. So the division will be carried a little further onto the right lateral wall of the bronchus, as is being done here, so that the openings in the stump of the bronchus and the lung bronchial bifurcation are of nearly equal size. We are now starting the anastomosis with the first vicryl suture in the posterior wall. This will go from inside out in the bronchus and outside in the posterior wall midline of the lung hilum. As you can see, due to the short length of the bronchial stump, the space to operate is rather limited here, but the two lumens can be seen to be getting approximated. One feature which helps is not to keep an excessive amount of stay sutures in the operative field, otherwise one is continuously trying to work around them while getting the sutures in for the anastomosis. So we are continuing the anastomosis, joining the posterior wall of the right main bronchus to the posterior wall of the bronchial bifurcation in the hilum of the right lung. You can see the lighter colored bronchial bifurcation coming together with the bronchial stump in the depth of the wound. It is not a very easy place to operate. After joining the posterior wall, we are now coming on to the anterior wall of the bronchus and the bifurcation in the lung. The anastomosis is almost complete. We can see the two front walls coming together there. The sutures are again going from outside in the tracheal stump and inside out in the bronchial bifurcation. With a bit of luck at the end of this effort, we expect to see the right lung inflating with the compression of the airbag by the anesthesiologists. And here we can see that for the first time the right lung of the child is inflating as the anesthetists compress the airway bag. For added security of the anastomosis, we are instilling tissue glue onto the bronchial suture line to prevent air leaks with inspiration and expiration. And we are now removing the stay sutures, and all that remains to be done is closure of the chest wall. We can see the right lung inflating nicely there. We had requested the anesthesiologists not to inflate with too much pressure, as that may cause an air leak from the anastomotic site. In fact, we can see a few bubbles escaping there. As there is a definite possibility of an air leak from the anastomotic site, we are leaving a small intercostal drain in position for 48 to 72 hours after the operation. The ribs are being approximated with 3O polygalactin sutures. 2 are usually sufficient, evenly spaced along the incision. A little more tissue glue was infiltrated at a site on the lung from where some air leak was seen. However, since this is a non-infective leak, we expect it to close off pretty rapidly in the post-operative period. A pair of Alice's forceps are being used as a rib approximator while the three sutures closing the intercostal gap are tied off. Closure of the serratus anterior and latissimus dorsi muscles is being done by continuous over and over interlocking sutures of 2,0-polygalactin. The intercostal drain was secured to the skin and the skin was closed using 3/0 nylon sutures. Post-operatively, we gave the child intravenous ceftriaxone and sulbactam together with amikacin for 5 days. The intercostal drain was removed after 72 hours when a chest X-ray confirmed expansion of the right lung. The child has been followed up for 3 years after his surgery, and apart from one episode of chest infection during the winter months, which was treatable by oral antibiotics, has remained healthy with normal growth and weight gain.